Welcome to this series of lectures in oral medicine, this one entitled Oral Ulceration. Oral ulceration. First of all, with regard to oral ulceration, the causes of which we need to make a list. But prior to doing that, let's define what ulceration is. Ulceration is a discontinuity of an epithelial surface induced by either traumatic, inflammatory, or neoplastic processes. And some of the causes as listed could be local causes such as trauma or burns, medications, recurrent aphthous stomatitis, malignant disease, systemic disease such as blood disorders or gastrointestinal disorders, mucocutaneous disorders, connective tissue disease, vascular disease, and infective disease, and others. This lecture will give you a broad overview on this list of causes or etiological factors. However, you will be expected to look at other lectures in the series as well as some background reading to fill in the gaps. So as seen in the picture in the top here, it shows a large fibrinous ulcer measuring over 2 centimeters in diameter with a red halo around the periphery. And it can be thought of as similar to a pothole on the road, where the road surface is broken down and you have the exposed underlying gravel. Here you have the exposed underlying connective tissue. And they can come in many forms. Here what you have is a white central area which is appears to be sloughy and no erythema around, and this is a malignant ulcer compared to a recurrent aphthous stomatitis on the top. So mechanical trauma from, for example, dentures or toothbrushes, especially those brushes that are old and worn, sharp teeth, or self-induced after local anesthetic injection because the patient doesn't have any feeling in that area and doesn't know whether they're biting the lip or not. Cheek biting, which is a neurotic habit, and other causes. As you can see here, sometimes the cause is obvious, and you can see that the imprint of the broken down teeth here on that ulcerated area, and again here the overgrowth of the lateral tongue fits nicely into the indentations of the teeth. And here again, an overextended oil-fitting denture in the lingual area can cause this type of ulcer. It can be due to a chemical burn or radiation-related burn. So burns, as I said, it could be chemical such as aspirin, or due to some heat such as eating pizza or pie. Clinically, these ulcers are usually single in an otherwise well patient, and cause of the problem often apparent, and management involves removal of the cause and review 3 weeks, but if no improvement, then you need to make a biopsy. 0.2% chlorhexidine mouthwash or hot salt water mouthwash 3 or 4 times a day for a week will also help with healing process. Drug-induced lesions. Many types of drugs can lead to lesions in the mouth, such as cytotoxic drugs, methotrexate used for immune suppression, agents leading to lichenoid reactions such as antihypertensives, antidiabetics, non-steroidal anti-inflammatory drugs, antimalarials, etc. Agents causing local chemical burns such as aspirin, as mentioned previously, agents associated with erythema multiforme such as sulfonamides and barbiturates. So here you can see the pattern, irregular pattern that can be seen in a chemical burn or a lichenoid reaction, or erythema multiforme, which creates generalized ulceration of the mouth and lips with blood-crusted lips, especially in the morning. So clinical and management involves cytotoxic course as non-specific generalized pain and painful ulceration. So management is generally supportive, and option of stopping or changing the drug is always there, but bearing in mind the general systemic conditions the patient is being treated for. Aspirin usually is a solitary and local, white in appearance as seen in this clinical photograph on the top. Again, stopping the aspirin or that being held in that area will help to heal up. If we look at recurrent aphthous dermatitis, there are three types. Minor recurrent aphthous dermatitis, which is a round ovoid regular ulcer with a fibrin centre and a red halo, measuring less than 1 centimetre generally in diameter, healing within 1 to 2 weeks, and can occur in most places. In comparison, major recurrent aphthous dermatitis are much larger, greater than 1 centimetre, lasting longer, 4 to 5 weeks, and often healing with scarring. Herpetiform ulcer, herpetiform, the name given to that because it may look like a viral infection, but it isn't. There's no viral involvement at all, and these ulcers are usually 1 to 2 millimetres in diameter and often will coalesce and cause a large ulcer to form. Recurrent aphthous dermatitis can occur in up to 20% of the population, typically start in childhood, and generally it will improve with age. Usually there's an unknown etiology, but it's suggested to involve T lymphocyte mediated immune reaction. Clinically there are three types as mentioned, but management will revolve around review and correcting any underlying blood deficiencies, which can occur in 10 to 20% of the cases. Treat any predisposing factors, use of 0.2% chlorhexidine mouthwash, topical steroids occasionally, 0.1% triamcinolone acetonide in oral base, tetracycline mouthwash in adults, or topical anesthetic mouthwash for supportive therapy. Other recurrent aphthous dermatitis may be associated with other diseases such as celiac disease, menstruation, query, stress, food allergy, especially chocolates and cinnamon, Behçet syndrome, and that can be any type of RAS that's involved, eye disease, reduced visual acuity, uveitis, retinal vasculitis, genital ulcers, which are also aphthous-like, skin disease such as erythema nodosum, arthralgia of joints, neurological disease, and immunological etiology. Immunodeficiency, HIV, can also give rise to aphthous, recurrent aphthous dermatitis, which tend to be a little bit more difficult to manage. If we now focus our attention on malignant ulceration, malignant disorders, majority 90% are oral mucosal squamous cell carcinomas. Other primary malignancies may be Kaposi sarcoma, which is associated with human herpes virus 8, lymphoma, antral carcinoma, and salivary gland tumours, as was covered in previous lectures. Metastases from the breast or bowel is more commonly may occur. The number of oral cancers from immune suppression is also rising, and evidence for this is Kaposi sarcoma and lymphoma. Clinically may present as a non-healing ulcer, which is chronic, indurated, with raised rolled edges and granular with a granular floor. Cervical lymphadenopathy may be present. Management involves referral to a specialist. These clinical photographs show the different types of clinical presentation of this type of malignant ulcer. Oral ulceration may also occur as a result of systemic disease such as leukemia and lymphoma. Gastrointestinal causes such as celiac disease, orofacial granulomatosis, Crohn's disease, and ulcerative colitis can also lead to various types of oral ulceration. Dermatological disorders that manifest in the mouth can also give rise to oral ulceration, ulceration, and these listed are epidermolysis bullosa, lichen planus, lupus erythematosus, pemphigoid, other vascular bullous disorders resembling pemphigoid clinically, including pemphigus, dermatitis herpetiformis, linear IgA disease, and erythema multiforme. Here are some examples of, on the top there, lymphoma, thrombocytopenia, and erythema multiforme. Leukemia involves malignant proliferation of leukocytes, granulocytes, basophils, eosinophils, mast cells, and neutrophils, which form leukocytes, and non-granulocytes, which are monocytes and lymphocytes. In acute leukemia, you get a rapid increase in immature blood cells, which prevent bone marrow from making healthy blood cells. Chronic leukemia, you get a build-up of mature but abnormal cells. Clinical anemia, you may get anemia, pallor, weakness, lymphadenopathy, spontaneous gingival bleeding, and oral purpura, intraoral herpes simplex ulcers, candidosis, and leukemic gingival deposits leading to swollen, boggy gingiva. For management, this requires specialist care and a full blood screen and a bone marrow biopsy. These clinical photographs show some clinical examples of leukemic lesions. Lymphomas, as has been covered in previous lectures, you get Hodgkin's lymphoma, which 50% have painless enlargement of cervical lymph nodes, and non-Hodgkin's lymphoma may produce lesions in the mouth, such as swelling of the lips, palate, tongue, gingiva, and lips. Herpes and candidal infection also may occur. These lesions may also be more prevalent in HIV or immunosuppressed patients. Here's an example of a non-Hodgkin's lymphoma in the palatal area of this patient, which gives that boggy appearance. Systemic disease, again continuing on the gastrointestinal. Celiac disease, which is also called gluten enteropathy, common in people of Celtic origin, and it's hypersensitive to gluten, found in wheat and other cereals. Oral ulcers occur clinically with angular stomatitis, glossitis, and dental hypoplasia. Management involves referring to a specialist, rectify any hematinic deficiency such as iron, folate, and vitamin B12 deficiency. In this clinical photograph, you see an ulcer that's prevalent in a celiac patient. Orofacial granulomatosis, where granulomas with no other detectable disease, but causes of granuloma in the oral lesion could be due to Crohn's disease, oral Crohn's, foreign body causing a granulomatous reaction, sarcoidosis, and tuberculosis. And the orofacial granulomatosis may occur due to a reaction to benzoate, cinnamon, carbonated drinks, antigens such as paratuberculosis. And so what you see clinically is a swollen lip or other parts of the oral mucosa, which, if you took a biopsy, would show these granulomas deeper in the connective tissue. So in Crohn's disease, which is a granulomatous condition which may affect any part of the GI tract, you get malabsorption, which will lead to iron and vitamin deficiency and leading to atrophy of the mucosa and ulcers. The patients may typically have abdominal pain, persistent diarrhea, anemia, weight loss, facial and labial swelling, angular stomatitis, ulcers, mucosal tagging. Gingival hypatia may also be seen, and lip swelling seen in isolation. Malchus and Rosenthal syndrome involves lip or facial swelling with fissured tongue and a lower motor neuron facial palsy. Management will involve referral to a specialist, oral biopsy for the presence of lymphedema, blood tests such as iron, vitamin B12, folate, serum angiotensin converting enzyme to exclude sarcoidosis, and a chest radiograph, and then correct any deficiencies. Other gastrointestinal ulcerative colitis, which is uncommon inflammatory bowel disease mainly occurring in adults. You get ulceration in polyps, and the polyps may undergo malignant change, and these generally occur in the colon. Persistent diarrhea, iron deficiency, weight loss. Oral ulceration involves irregular mucosal pustules called stomatitis vegetans, which is this erythematous area with these 1 to 2 millimeter diameter pustules distributed throughout. Again, management involves referral to a specialist, a biopsy, blood tests, and sigmoidoscopy may be required or will be required, and use of topical and systemic steroid for the oral ulceration. Other systemic diseases are dermatological disorders, epidermolysis bullosa, lichen planus, lupus, erythematosus, pemphigoid, and other vesicular-bullous diseases resembling pemphigoid may cause oral ulceration. Epidermolysis bullosa is a rare genetic defect in which the basement membrane proteins cause the skin to blister after minor trauma, and it heals with scarring, and the bullae may arise in the mucosa as a result of sucking. Again, management would involve referral to a specialist. Erythema multiforme is an uncommon recurrent disorder of mucocutaneous tissue, often in young men, and characterized by blood-crusted lips and target lesions of the skin. Etiology is unclear, but infection by herpes or mycoplasma may be present, or presence of drugs such as sulfonamides, barbiturates, hormonal triggers. The minor form affects one site, mainly lips cracked and bleeding, ulcers are diffused, widespread, rashes, target lesions, ocular and genital lesions. The major form is Stevens-Johnson syndrome, which creates widespread fever, arthritis, myocarditis, nephritis. Toxic epidermal necrolysis, which is the worst form, usually have drug-related, may be associated with HIV as well, so you need to be aware of that. And these are some of the target lesions that you can see on the skin. This desquamative gingivitis can be a feature of pemphigoid and other mucosal diseases. Pemphigus vulgaris here showing generalized ulceration of the mouth. Management of erythema multiforme involves referral to a specialist, quite often managed in the hospital. Dermatological disorders such as lichen planus, common mucocutaneous autoimmune disorder involving T lymphocytes, and may present clinically as bilateral striae, papules, erosions, atrophic areas of the cheek, tongue, palate, and also affect the skin, genital areas, scalp, and nails. These are some of the clinical presentations that may occur. Again, a desquamative gingivitis may occur with lichen planus. There is a malignant potential suggested to be in the order of 1 to 3%, and it may be also associated with drug-induced or lichenoid reactions due to antihypertensives, antidiabetic, gold antimalarials, reaction to amalgam, hepatitis C, chronic liver disease, graft versus host disease. Management involves confirmation with biopsy, excluding any predisposing factors, drugs, amalgam, or systemic disease, and symptomatic lesions are treated with topical steroids. Thank you very much.